It's a busy morning. You're moving from room to room, trying to keep up. Just before you see your next patient, the charge nurse stops you. Hey, they're sending you a patient from clinic who just needs an IND, she says. Looks like a buttock abscess. Oh, okay, thanks. You're trying to make yet another mental note, but you just don't seem to have much room on your brain's scratch pad right now. Vitals are okay, and about how old? Yeah, they didn't give them to me, but the kid seems fine, she says. They have an appointment with the surgeons tomorrow, but the family just doesn't want to wait. You know how we aim to please. Oh, you know. Thanks for the heads up, you say. She turns to get back to her assignment, but something stops you from turning the door handle fully. Jen, I'm sorry, what clinic did you say called? I think it was genetics. Oh.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Do you ever feel like the world is conspiring against you? No, I mean at work. Let me narrow that down. I mean, while you're trying to do your job, sometimes it feels like there are minefields everywhere. The scariest minefield is the one buried in complacent expediency, aka, let's just get it done. We perform procedural sedation all day, every day, and it's a good thing. We offer a much-needed service to our community, and when we do things well, it's as safe as it can be. Although most children who need procedural sedation, they're healthy and all goes well, we just can't rely on good fortune to stay safe. We need a thoughtful approach that helps us either to tailor our sedation appropriately, or, here's the kicker, not to sedate in the emergency department because the real risks outweigh the possible benefits. With the advancement of medicine and technology, we are seeing more and more complex patients. The push not to admit or just get the ED to do pretty much everything is a real stressor and a slippery slope. There are times when we should trust our training and know-how and not kick the can down the road. We do this all the time. We take charge. We are, after all, here for our patients. But there are other times when it's important not to be pushed down a slippery slope for the arbitrary convenience of others or because the system dictates it. Now, we're all one big team, and this is not meant to be an us versus the world talk, but to be good advocates for our patients, we have to be aware of not only our effect on our patients, but the system's effect on them as well. Simply put, we're always balancing safety and efficacy. When to proceed and when to no seed is up to us. What are our tools? The most ancient of all, history and physical exam. Just for a little perspective, the anesthesiologist will cancel an elective case at the drop of the hat. You had a cold recently? Reschedule. You drank some water just now? Reschedule. Someone said the word food in the other room just now? Cancel, cancel, cancel. We don't have the luxury of choosing when our patients come in and what they may have done before we see them, but we do have the luxury of using every piece of information at our disposal to keep our patients safe. So, let's do some pre-sedation screening, shall we? On history, make sure you know everything about this child's birth history, gestational age, did mom and baby go home together or not, any surgeries, reactions to previous anesthetics, medical history, medications, last PO intake. Don't assume. More times than I can count, a parent brings in a child with an obvious syndrome, for example, and when asked about any medical problems, no, she's healthy. When gently asked about any syndromes, to them, this is who the child is, and they're right. She isn't a list of medical problems. She does have special needs. And oh yes, by the way, there is a heart problem and there is a kidney problem and all of those other things that come with it, but she is who she is. especially to the parents. Now, it's important to try to understand the parents' perspective because, again, it's not a problem because they're working on it. Maybe a way around this potential communication breakdown is to ask about any medical history or any problems in the past. Find your way around the potential communication pitfalls. Find out everything you can now. Better now than during an adverse reaction. The physical exam is your one shot to understand the patient's baseline physiologic status. Is this child a little tachypnic right now? Is there an unexpected fever? How many times have you seen someone with, say, minor head trauma and a headache and, oh, by the way, we found a fever? Is it related? Is it not? If you're going to change someone's physiology with procedural sedation, you better know what it is before you started. Perform a targeted physical examination, including especially airway assessment, respiratory status, and volume status. Part of the pre-sedation screen is, of course, Npo status. What was that? I think I heard you groan just a little right now, if not internally. It's okay. I'll start with the punchline. The American College of Emergency Physicians policy on procedural sedation states that in patients undergoing procedural sedation and analgesia in the emergency department, we should not delay procedural sedation in adults or children based on fasting time. Pre-procedural fasting for any duration has not demonstrated a reduction in the risk of emesis or aspiration when administering procedural sedation and analgesia. Unquote. Now, there's a more nuanced table involved in this, but that's the bottom line. The concept here is, if you do need an emergent procedure that requires sedation, then all the risks of delaying it outweigh the risks of aspiration, which luckily are small. A lumbar puncture in an irritable infant or toddler who just ate some crackers? Gotta do it now. Sedation's okay. Broken bone, it needs realignment in a school-age child who just ate a hamburger? Let's do this. Ingrown toenail in an anxious teenager with chips in his hand? Nope. I can't think of a situation in which we just have to get that toenail out now. The risks of aspiration, however small, very much outweigh the tiny benefit of doing this elective procedure emergently with sedation, no less. So these are just some very simplistic examples, but maybe your threshold to sedate is lower in, say, an autistic child, or in someone you know has limited access to care and no one else is there for them. Luckily, experience is on our side when we talk about the risk-to-benefit ratio here. We also know from targeted research, the traditional teaching is that the risk of aspiration increases with gastric acid volume greater than 0.4 mLs per kilo and a pH of less than 2.5. Splinter et al. In Anesthesia and Analgesia remark that even if you apply the strictest elective fasting guidelines, many children would still have enough volume of gastric contents present to be at risk based on this old teaching. So we shouldn't fool ourselves. The stomach is rarely completely empty. Even in the fasted state, we have ongoing salivary secretions, in case you wanted to know, at 1 ml per kilo per hour, and gastric secretions, again, at 0.6 mLs per kilo per hour. So you've always got something in your stomach. It's helpful to know that when pulmonary aspiration does occur, it's most commonly with manipulation of the airway. In one study in general anesthesia in children, when the rare event of aspiration happened, 2/3 of the time it happened during manipulation of the airway, so either an endotracheal tube placement or removal. So when we're talking about procedural sedation in the ED, it's generally safe, but it's safe because we are using our heads and paying attention to whom we should sedate and whom we should not. Which brings us to when not to proceed. There are times when it just ain't that serious. It's okay to delay a procedure because it's not emergent or because the risk of doing it in an uncontrolled environment is just too high. Normal teenagers who just want to be knocked out and maybe just need simple laceration repair. A good example of not to proceed with procedural sedation. The risks, however small, are still there, and if something goes wrong because you gave unnecessary sedation, everyone is toast. Or on the other end of the spectrum, let's say you have a 3-week-old with a large buttock abscess that will need major deloculation. Could you get away with some local anesthesia and maybe some systemic analgesia? Maybe. Will this very tiny human be sedated and prone? Yes. Should this be done in, say, the operating room? Probably. My point is that although it seems like the whole world comes to us for every imaginable problem, we are not the answer to every imaginable problem. Other floors of the hospital exist. They even have electricity and telephone lines there. Science is not so heavy that it needs to stay on the ground floor. We have other working people here, so why not get them engaged in their own work? In short, we are the safety net, even within the walls of the hospital. You may just have to defy gravity. Okay, enough stalling. Let's talk about how to tailor our procedural sedation for special circumstances. We'll just run through the highlights of what we should know and do for some common and not so common presentations. Let's start with the most common comorbidity, asthma and reactive airway disease. After the toddler and preschool period, non-atopic wheezers continue to experience wheezing with any active viral illness, but they're not likely to develop lifelong symptoms. Atopic wheezers, they're equally sensitive to viral illnesses, but they'll also suffer from allergy, allergic rhinitis, atopic dermatitis. These children, these atopic children, are at highest risk for severe and persistent symptoms and for complications during sedation. Ask and look for atopy. Make sure they aren't experiencing an active exacerbation when in front of you. The children who have persistent symptoms may look relatively well to you until you hear widespread wheezing, not an ideal sedation candidate outside of the operating room. A recent prospective study found that patient factors like active respiratory symptoms, eczema, family history of asthma, rhinitis, or exposure to tobacco smoke, they were associated with an increased relative risk of peri-procedural respiratory adverse events like airway obstruction, oxygen desaturation, and severe or sustained cough. Just be sure you know how bad the asthma usually is and how bad it is today. Children with intellectual disability, developmental delay, or autism spectrum disorders, they need us to take a holistic view of their care. Their caregivers are typically very helpful in sharing the child's past reactions to a procedure, and they may be very vocal in their preferences in the timing, the type, the route of administration of sedatives. It's a good idea to listen. They know their child best. These children may exhibit challenging behavior, especially when they're anxious or they're stressed. They can punch or pull or kick or slap. Young and adolescent boys are the majority of the challenging patients here. Just keep in mind that these behaviors may be exacerbated by frequent and sometimes unpleasant interactions with the healthcare system. This is where non-pharmacologic techniques like distraction or storytelling or watching videos or playing games, they're particularly helpful in preparation. The most important pearl here is that intellectual, developmental, and learning disabilities, they're not a specific medical condition, but they're manifestations of a neurologic disease. So comorbidities are common, like epilepsy, or psychiatric disorders, or even gastroesophageal reflux. For example, is a benzo a good idea? Maybe, but it can be disinhibiting. Did it work for them before? Great. Is ketamine okay? Maybe, but hopefully the child is calm enough going into the ketamine sedation, or he's going to be just as challenging coming out of it. Each patient has his own history. Engage the parents and get their take. They have definitely seen this movie before. Speaking of which, get all of your staff all on the same page. You need buy-in from everyone so that they have your back if it's not all smooth sailing. Know your patient, know your pharmacology, including the intended and unintended side effects. The cannabis plant contains over 500 chemical compounds, of which over 100 are active cannabinoids. The cardiovascular effects of marijuana use range from benign to worrisome based on the timeline of use and their dosage. Low doses of cannabinoids can produce an increased sympathetic activity with tachycardia and hypertension. At higher exposures, parasympathetic tone is enhanced, so we'll see a lot of dose-dependent bradycardia and maybe even hypotension. Synthetic cannabinoids are associated with malignant arrhythmias, coronary artery spasm, and sudden death. Cannabis smoke has been known to cause uvular edema, something that we should check for and know about before sedation. In addition, if a child or adolescent is high in front of you, ethical questions about consent from caregivers and truly assent from the patient himself come into play. Cerebral palsy is a non-progressive, permanent disorder of motor function and posture, and it's the most common physical disability in childhood. The spectrum of disease varies from mild focal weakness with normal intellectual ability to total body spasticity and severe intellectual disability. Many patients take medications to address spasticity or ataxia or dyskinesia. Ask about seizures, chronic lung disease, difficulty with secretions, and reflux. Look for work of breathing at baseline, the presence of scoliosis, potential difficulties in placing the child in sniffing position. Children with CP often have considerable drooling due to difficulty in swallowing secretions, so plan for frequent suctioning. You may think to give atropine or glycopyrrolate for their anti-sialagogue effect, but that may also thicken lung secretions and potentially increase the risk of lung infection in CP patients. Poor feeding contributes, of course, to malnutrition, anemia, dehydration, electrolyte imbalance, and chronic low fluid intake and relative malnutrition put the child at risk for pre-renal failure and for the development of pressure ulcers. So be careful, pay attention to fluid replacement if you need to, especially if there's prolonged fasting periods before you do this. And remember that you need to optimize the child's positioning in the procedure to help attenuate all of these risks. Congenital heart disease. All you need to know about this is that children with cyanotic heart disease, like hypoplastic left heart syndrome or an unrepaired tetralogy of Fallot, these children should not undergo sedation outside of the operating room. They are very sensitive to changes in volume status, as many of them are preload dependent and they're prone to dysrhythmias. Their low baseline oxygen saturations will give you almost no reserve in times of stress. So for this reason and in general, children with cyanotic heart disease are poor, non-emergent outpatient candidates for sedation beyond mild anxiolysis. Cystic fibrosis is a multi-organ system disease involving impaired lung function, pancreatic insufficiency and diabetes mellitus, hepatobiliary disease and cirrhosis, bone disease, and genitourinary disease. Pulmonary complications account for over 90% of the morbidity and mortality here. In addition to acute exacerbations and worsening lung infections, children with CF are at risk for apical blebs, that can cause spontaneous pneumothorax. We just have to be ready. The only real deal breaker in patients with cystic fibrosis who need procedural sedation is nitrous oxide. Just don't use it. Nitrous oxide has an interesting gas coefficient. It causes it to preferentially flood into air-filled spaces, like, say, a bleb. You can cause a pneumothorax in a cystic fibrosis patient with nitric oxide. Diabetes mellitus. We can talk all day about this one, but here's my friendly reminder that the overall goal during sedation is to avoid hypoglycemia and excessive hyperglycemia, especially in children who've been NPO for some time while we get our acts together. Case reports demonstrate the importance of glucose monitoring in diabetic patients undergoing sedation. Hypoglycemic coma may be confused for deep or prolonged sedation. Let's move on down the road to endocrinopathies, but briefly. Patients with primary hypopituitarism always need periprocedural steroid supplementation regardless of the daily dose taken. Patients with hypothyroidism can have impaired cardiac contractility with decreased cardiac output, increased peripheral vascular resistance, and decreased blood volume and peripheral oxygen consumption. Patients with hyperthyroidism must be euthyroid before the procedure. Physiologic stress, even in sedation, has been known to precipitate thyroid storm. Children with diabetes insipidus can display intravascular volume depletion with resulting decrease in cardiac stroke volume. Think orthostatic hypotension, weak pulses, rapid breathing, and decreased level of consciousness. The punchline is that children with diabetes insipidus need their usual morning dose of desmopressin before sedation. Moving right along down our list of disastrous pitfalls in procedural sedation, we have our winner, mitochondrial disease. These children have defects in oxidative phosphorylation and electron transport chain production in mitochondria, so basically generation of their ATP. So if you give them something that messes up their ATP production, you're going to have some trouble on your hands. They are all at risk for cardiovascular complications, for neurologic and metabolic complications from any sedative. They often will get hypoglycemic or have lactic acidosis. For this reason, propofol is a big no-no for these children. Honestly, there are too many interactions to count, but luckily, they all do well with inhaled anesthetics, which to you and me means OR time. The muscular dystrophies are a group of progressive myopathic disorders characterized by muscle wasting and weakness, and most involve some degree of cardiomyopathy. All of them are at risk for heart failure. And for these reasons, the AAP recommends that these children should undergo a cardiac evaluation and optimization of cardiovascular status prior to elective anesthesia, which often leaves us in the ED completely out of this loop. So unless this child has some vastly emergent problem, they need to go to the operating room. At this point, I know what you're thinking. Tim, when am I going to see any of these cases? Well, you don't see them until you see them. We have to be ready. But hey, let's give the less common scenarios a break for a moment and talk about an increasing burden of disease in children: obesity and obstructive sleep apnea. OSA is a sleep-related breathing disorder in which the airway can become completely occluded, leading to apnea, or it can be partially occluded, leading to hypopnea, despite their respiratory effort. This leads to abnormal gas exchange. And remember, sedation is not just sleep. It's a deeper depression of consciousness. whatever issue at baseline they may have is exacerbated with sedation. Ask about a history of snoring, paradoxical breathing, episodes of apnea, mouth breathing, behavioral disturbances, and restless sleep. In cases of severe OSA, pulmonary hypertension can develop. They get pulmonary vasoconstriction, and that can then cause right ventricular failure and cor pulmonale. Luckily, this presentation in children is not as common, but you need to take a look and pay attention. The Stop-Bang questionnaire was introduced and validated as a screening tool to identify obstructive sleep apnea in adults. Recently, we have more evidence to use them in children and adolescents. We have a modified Stop-Bang questionnaire now. In the show notes, you'll see both for adults and teenagers. So the teen Stop-Bang is, do you snore loudly? Do you feel tired during the day? Has anyone observed you stop breathing? Do you have any pressure problems, blood pressure problems, so greater than 95th percentile? Is your BMI greater than the 95th percentile? Do you have any academic problems? Is your neck circumference greater than the 95th percentile? And is your gender male? Of note, in adults, A is for age greater than 65, and neck circumference is greater than 40 centimeters, or greater than size 16 in the US. So that's snore, tired, observe apnea, blood pressure, academic problems, neck, and gender male. If you have 2 or less of these findings, then you likely don't have obstructive sleep apnea. Cote et al. Found that in adults with a Stop-Bang score of 3 or greater, this was predictive of the need for airway intervention, so something like a chin lift or mask ventilation or a nasal airway or even an endotracheal intubation, and also for oxygen desaturation less than 90% with propofol sedation. Now, these are easy things to ask and to figure out in the ED, and it can save you a lot of stress. The Stop-Bang questionnaire, it's free, it's easy, you could do it at the bedside. Remember that children with obstructive sleep apnea, they're very sensitive to respiratory depression by opioids, sedatives, or hypnotics. They're especially vulnerable to the development of upper airway obstruction during sedation anesthesia. And here's the kicker. In children, this may not have been formally diagnosed. You may be the first person who can actually quantify their risk for obstructive sleep apnea, and you may save their life by not sedating them. Sedatives like diazepam, midazolam, they relax the pharyngeal musculature and they cause a reduction in the pharyngeal space. Propofol, barbiturates, and opioid analgesics and sub-anesthetic concentrations of inhalational agents can also exacerbate upper airway obstruction and increase the risk of respiratory depression and apnea. Now, not to be all doom and gloom, there is a way out. If you have to sedate a child with obstructive sleep apnea, you have a nice new tool in your belt. Dexmedetomidine may be a great choice for children with obstructive sleep apnea. It induces a state that mimics non-rapid eye movement sleep without significant respiratory depression. Increasing doses of dexmedetomidine in children without OSA have minimal effect on their upper airway, and they're not associated with clinical signs of airway obstruction. So, if you have it available to you, it's a great choice in procedures that are non-painful. When all is said and done, of course, ketamine is pretty much always the right answer. Ketamine has been shown to preserve hypopharyngeal caliber in adults and children. The premature infant. I think you already know what I'm going to say here. Preemies can get sick very quickly. They are struggling to adapt to a new environment, and they're trying to catch up in their development at the same time. Age is an important number here. Apnea at baseline is a real concern, and as I mentioned, sedation is not just putting someone to sleep, it's a deeper level of consciousness than sleep. Kurth et al. Studied the breathing patterns of 47 preterm infants less than 60 weeks post-conception with pneumocardiograms before and after general inhalational anesthesia. There's a lot to unpack here. So post-conceptual age is the number of weeks after conception. So let's say ideally a full-term baby is born at 40 weeks. He's now a month old. So that would give him a post-conceptual age of 44 weeks. 40 plus 4. It's not really relevant in full-term babies, but it's helpful when we try to gauge the development of premature babies. For example, a child born at 30 weeks, premature, now is also 1 month old. His post-conceptual age is 30 weeks plus 4, because he's a month old. So his post-conceptual age is 34 weeks. Now, he's not the same as the other child, even though they share the same birthday. We know that his development is not the same. So we use post-conceptual age to risk stratify preemies as far as how developed they are. Since apnea is a common issue, often the NICU will do what's called a pneumogram. It's also called a pneumocardiogram. It's basically a baby sleep study to see if there are desaturations or bradycardias during sleep. Since these children are especially vulnerable during sedation anesthesia, Kurth et al. Conducted this study, and they found that 18 infants, so 37%, had prolonged apnea of greater than 15 seconds, and an additional 7 infants, so 14% of the participants, had a short apnea, so 6 to 15 seconds postoperatively. The authors concluded that preterm infants younger than 60 post-conceptual weeks of age should be monitored continuously for at least 12 hours post-op in order to prevent apnea-related complications. So this does have some ramifications for us. So based on this, many institutions will recommend that all premature infants, so anyone born before 37 weeks gestation, and they haven't quite completed 60 weeks conceptual age, they should be monitored for post-op apnea for a minimum of an overnight stay in an ICU setting. So that means that even the X35 weeker, who you're not particularly worried about based on other criteria, he is now 6 months old. So again, someone that may just fly under the radar, he should stick around after sedation overnight. So this brings us to a bigger issue of sedating very young children. Remember that ketamine is contraindicated for any infant less than 3 months of age. Full stop. They become apneic. Don't do it. This also brings up the point that if you're sedating a young infant, say less than 6 months, you also have to ask yourself, would this be safer and more controlled in the operating room? The answer for these very young infants is often yes. For any young infant, remember they are hypermetabolic. So all of them, remember to keep all of them euvolemic, keep them warm, and not hypoglycemic. Children with sickle cell disease are at risk for deoxygenation stress on hemoglobin S polymers, resulting in a process called gelation. Red blood cells subsequently become less able to deform normally as they pass through capillary beds, which may result in vaso-occlusion and infarction. Even fully oxygenated blood in a child with sickle cell disease is more viscous than in non-affected individuals. Make sure you find out what the child's typical crisis looks like before you sedate them, you stress them out with these medications. Take a careful history of past sickle cell crises, so acute chest syndrome, splenic sequestration, hemolytic crises, stroke, priapism, cardiomyopathy, renal disease, avascular necrosis. Again, don't assume. They may just think that you've already looked in the EMR. Careful neurologic examination is essential, and documentation of any pre-existing neurologic deficit is very much recommended. You'll want to be well informed about the child's baseline status before you go stressing out his physiology with sedation. The biggest point here is that volume depletion or dehydration will accentuate their baseline hyperviscosity and promote vascular stasis. Since these children get poked all the time and their veins just get wrecked, try to spare them if at all possible. And if you can, consider liberal use of intranasal medications or oral medications or even intramuscular medications if you don't really need that IV. Okay, let's talk about syndromes and sedation. Now, there are too many to do them justice. So your main homework here is when you see a patient with any syndrome, take a moment, look it up, understand what the child is at risk for, and pay attention to common problems like abnormal airway anatomy. Mandibular hypoplasia and macroglossia can be found in Beckwith-Wiedemann syndrome, or Cornelia de Lange syndrome, or arthrogryposis, Crouzon syndrome, DeGeorge, Goldenhar, Pierre-Robin, Treacher-Collins. Oh, do I detect an impulse to open Google and start searching? Good. You should. Even the child with Down syndrome, who looks like $1,000,000, can have a difficult airway if you start sedating him, and he may not be an appropriate sedation candidate outside of the operating room. Premonitus, premunitus. Forewarned is forearmed. By the way, premonitus, premonition, similar to English premonition, so forewarned. Premunitus, munitio, like munition, ammunition, pre-armed. Premonitus, premunitus. Forewarned is forearmed. If not, then hasta la pasta. One special word about children with Down syndrome, because it's not uncommon, you're going to see this relatively frequently. They often have comorbidities like a VSD or obesity or subglottic stenosis, endocardial cushion defects, atlantoaxial instability, and just general hypotonia. So they should get our attention. These children are particularly sensitive to respiratory depression by opioids and sedatives and hypnotics. They're especially vulnerable to the development of upper airway obstruction when we give them sedation. So the most common sedation-related complication in patients with Down syndrome is going to be bradycardia, especially during induction. This may occur even in the absence of heart disease. So if you find yourself with a child with Down syndrome and you may think that everything's fine, you gave an intranasal med, that's okay, but he happens to become bradycardic, have IM atropine ready. Now, this isn't to scare you, but then again, premonitus, premunitus. All right, enough of this craziness. Let's wrap it up with a bread and butter comorbidity that pretty much every child in the PD either has right now or is getting over currently or will get right now because they're waiting to see you in the PZD. Upper respiratory tract infection. This is the bane of existence of anesthesiologists who will often cancel procedures based on URI symptoms, and not without some reason. Any virus can induce a hyperreactive airway, even in children without previous reactive airway disease. Inflammation from a URI can persist for up to 6 weeks after apparent resolution of symptoms. An active URI may put the child at risk for laryngospasm, bronchospasm, severe coughing, major oxygen desaturations, airway obstruction, pneumonia, and an unanticipated admission. There have been at least 2 reported deaths in pediatric patients who underwent surgery with a history of a URI. So it's not a nothing. But then again, it all boils down to our basic tenet of risk-benefit analysis. If the patient needs it, he needs it, and we just have to accept the risk. Or not, depending on the specific situation. It's ultimately your call. Remember that. If you're feeling on the fence about a child who would otherwise get, say, ketamine, who has an active, gnarly URI, there is some evidence basis to help us to risk stratify. It's called the COLDS score, COLDS. The COLD score is a recent scoring system that can be used as a risk assessment tool for anesthesia providers to assist with decision-making and as an educational tool for patients' families. C stands for current signs and symptoms. O, onset of symptoms. L, lung disease. D, for the device to be used for airway management, so an LMA or an endotracheal tube. And S, for the surgery type. Again, this is really for OR literature, but I think it helps us to give a type of cognitive construct for ourselves and also to talk to patients about what the best thing is for them. So the intention of the score is really to give a relative gestalt, and each category has mild, moderate, or severe designations to it, and the full description will also be in the show notes. For example, C for cold is 0 for none, 1 for mild rhinorrhea, and up to 5 for purulent discharge. So for us, it's just a nice framework to talk about cold symptoms, onset, lung disease, anticipated device to be used, and type of surgery. Again, this was designed and validated for anesthesiologists for OR use, but I mention it here because if you get some pushback, you feel that this child should not have an elective procedural sedation in the ED, or if you feel like it's safer in the OR, you can use this information to speak with your colleagues. You can have some objective score to point to and explain to your subspecialists your concerns. If anything, it will get your anesthesiologist to have your back. Let's bring this all together. You are sometimes the child's last safety check before possible disaster. We can do a lot in the ED, but the question always remains, should we? And if that answer is yes, then we had better know everything we can to a reasonable degree. And a good history and physical is always reasonable before we change the child's physiology. In other words, you gotta know when to hold them and know when to fold them, know when to BVM and know when to send them to the OR. Or, if you like, premonitus premunitus. Forewarned is forearmed. Thank you for listening, and until next time, remember, defensor puere ante te es tu.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.